When I look at this screen, it reminds me of the Brady Bunch.
Yes, it very much does.
After a really rough weekend, by the way.
Mm,
I just asked for Ash. I just text Ashley.
okay, thank you.
Let's see.
All right. So let's talk about documentation real quick. And this is one of my absolute pet peeves. Is people who don't document appropriately. Um, if you ever get pulled into court for something, you really need to make sure that your documentation's on point, right? So why did you do what you did? Why did you do what you didn't do? Like, were you using protocols? Did you use the protocols correctly? Does your flow chart match your narrative? Okay, everything needs to be thorough, and that's going to take a little bit of time. And yeah, there's going to be here and there where you might forget one thing, or in the flow chart, you might forget, something in the narrative. But as long as it's relatively close, you're in good shape. One thing I also can't stand is people who have these like really short narratives, like showed up, did things, went to the hospital, and you're like, that doesn't tell me what happened. That doesn't give me a clear view of the scene, and what was going on with the patient. uh, Objective versus subjective. I am one of those people who constantly kind of forgets the difference between these two and always has to look it up. So objective information is stuff that you can measure and observe, right? So you can walk in and see the patient is in tripod position. That's objective information. You can take a blood pressure. That is objective information, as opposed to subjective information, which is the patient's experienced symptoms, right? Stuff that you can't experience, but they are. So I'm having chest pain. I can't breathe. My pain's a 10 out of 10. That's all subjective information that is kind of related to the patient and their perception of it and their personal experience. But when you're presenting this information, you need to make sure that you do it free of bias. Just because you happen to be picking up a chronic caller does not mean that you need to be like, this guy. Like, okay, we get it. Like, you've picked him up a number of times. He might be known to EMS. Patient is known to EMS to be a chronic, caller, secondary to alcoholism, or issues with alcohol. But like, you can't be like, this guy smells and he calls all the time and he's a pain in the butt. Like, that's inappropriate. You have to be very professional and straightforward. This becomes part of the patient's medical chart, right? Is a legal document. Okay. The PCR or ACR, depending on where you are, is the only record of what occurred on scene and on the way to the hospital. So, especially when it's a he said, she said situation, right? When the patient's like, well, they didn't do this for me. Okay, but maybe there's a reason, right? So patient says they're having an asthma attack and that they took, 15 pumps of their inhaler without relief, and then you gave them a nebulizer and you wanted to give them dexamethasone for their, continued help, and they said, no, I don't want a needle, don't give me a needle, and now they're complaining that you didn't give them the needle. Okay, so you need to have signatures, you need to have a clear and thorough documentation. Numbers of reasons that we do PCRs, beyond the fact that it's part of the patient's legal record or legal medical record. It's helping to ensure continuity of care, okay? Like, how many times you walk into the hospital and you're trying to give a report and a new doctor pops up and they're like, oh, can you start over? Or a new nurse comes in, it's like, oh, can you start over? And then, or you're standing just doing your documentation and one nurse comes over and talks to the triage nurse and it's like, oh, what's up this patient? And they give a completely different story from what you said. That's why your documentation is important, because when all of a sudden the game of telephone starts to happen and 3 nurses down the road, the patient came in by ambulance with, a shark bite instead of a dog bite, at least it's written down somewhere what's accurate. Minimum requirements in billing, right? So there are different levels of billing that we as EMS providers can do. So it's the most basic, obviously, is BLS. They actually just authorized that we can start billing for RMAs. in parts of New York or in certain agencies who have that set up. So you can bill for RMAs. You can bill for BLS transport, and that's going to be a certain amount of money. You can bill for an ALS-1 transport, which is a certain amount of money. You can bill for an ALS-2 transport, right? And it depends on what's being done. So like an ALS-1 transport is going to be your monitor vital signs and an IV, whereas ALS-2 might be you cardioverted, okay? Or you did something more invasive like intubate. EMS research, we talked about this a little bit last week, that how there's really not a lot of EMS research going on when it comes to patient care. And even though the stuff that is being performed, it still takes 17 years for that to trickle into daily practice. So when we have good data from PCRs, then we have the ability to maybe make better change and do patient care better. Things like CPAP, right? That's like we kind of push that into practice because it was doing really good things in the hospital, and we were like, why can't we do this in the ambulance? We have the power, and it finally came down, and now it's okay. Well, it was only when you had certain qualifications and you called and asked and got CPAP. When I first became a medic, that was what you had to do. You had to call and get permission for CPAP for anything other than acute pulmonary edema. Now it's, you having a hard time breathing and this normal breather's not doing anything? Cool, here's CPAP. Like, doesn't matter what the cause of the difficulty breathing is, doesn't matter what else might be going on with the patient, as long as they're not, unconscious, you can pretty much put CPAP on them. But again, you still need to work within your guidelines. Quality assurance and incident review, these two kind of tie in together pretty nicely. Right, we want to make sure that we're providing high quality patient care, but there are going to be some incidences here and there that are going to need to be reviewed. And what caused the incident, right? What situation arose? Maybe it was an outlier, right? Maybe you work in, I don't know, Bayshore Brightwaters, and the ambulance got stuck behind a train track crossing that was down and extended the time onto scene, and the patient who was having a bad asthma attack went into respiratory arrest. Is that the provider's fault? No, they couldn't have necessarily avoided the train track. So that, as long as it's documented, was, delayed at the train crossing, you're covered. But if it was, we, took 5 minutes to put on our boots after the call was dispatched and the patient went to respiratory arrest, you don't have a good, reason. Or we didn't, over here on the quality assurance side, we didn't give the patient a nebulizer. We just put him on oxygen, went to the hospital, right? So a lot of different reasons that we want to make sure that the PCR is thorough. The most minimum data set that you're going to need in order to submit an ACR is as follows here, right? One thing that is not necessarily true of 100% is the patient demographics. There are going to be times when you don't necessarily have information on a patient. It might be a DOA, it might be a number of different situations a patient refuses, right? So maybe a 90, we call it in the city, it's a 93 refusal in RMA. They just get up and walk away. They don't want anything to do with you. You might not get patient demographics on that one. That's when you kind of guess. And then again, it's going to depend on your agency. Most agencies, you put in the patient's name is unknown, and you make up an approximate birthday, and you're good from there. Again, vital signs also, if the patient refuses to allow you to take vital signs, at the very least, you can probably get respirations, right? You can be like, 14. But, sometimes those two might be challenging to get if you have a patient who either is a DOA or doesn't want to participate at all. You have to have a PCR. You have to document what you did and what you did not do. Documenting that you left the patient with, the nurse at triage, and then you have a signature with a nurse's name. You're good, right? You've done everything you need to do. There's no possibility of negligence. There's no possibility that you've... My landscaper's just got here, so the dog's losing his mind. It needs to make sense. It needs to have a logical beginning, middle, and end. The story, literally, of every single ambulance call you ever go on. but it also needs to be like relatively easily understood. And this is when I say like, hey, like if you aren't sure of a term, use your phone. Your phone is got the internet on it. You can find anything. If you're not sure of a Gray Turner sign versus Cullen sign, which one's which, right? Maybe you're having a brain fart that day. You can look it up and make sure that you document things appropriately. If you aren't sure of the spelling of something, you can look it up. I had one of my medics ask me the other night if the difference between lay and lied, like for the patient, is like laying on the ground. Is the patient lying on the ground or laying on the ground? And we went on a little like rabbit hole down the internet to figure out the difference between the grammar of those two versions of the word, because English is hard. English like mugged other languages for its context. So it's okay to be confused, but it's not okay to then not follow up. So just make sure that you are doing everything that you need. This is also one of my pet peeves, is that sloppy documentation implies that you have performed sloppy patient care. So if you have spelling mistakes, grammar mistakes, you've decided that you could care less about using punctuation, I don't necessarily have confidence in you as a patient care provider, because it's sort of like if you show up on scene and your shirt's untucked, your boots are untied, and you look like a hot mess, I'm not going to have confidence in you as a patient care provider. It's kind of like they run hand in hand. So if you are going, how do I put this? So if you're going to want to present yourself as a professional who is to be trusted and takes very good care of their patients, also take just as good care with your documentation. Refusals are one of the trickier areas of documentation. Hold on one sec. Because this is the area where everyone gets really nervous about having some sort of liability. If you're going to RMA a patient, and trust me, there's plenty of times when it's perfectly acceptable to RMA a patient who called because they were, they're not actually experiencing a medical problem. They just, quote, wanted to get checked out. They have no actual medical issues with them. And this happens very frequently. It's not the end of the world to RMA somebody, but it's those patients who are kind of on the in-between, right? Where they're like, I was having some chest pain, but it went away now. Okay, well, what's your medical history? Oh, well, I have high blood pressure and I have 2 stents. Okay, you really need to go to the hospital. No, I just don't want to. I want to go with I want to go follow up with my cardiologist. Okay, like, that's reasonable, but, like, you had an event that really needs to be evaluated. Nah, I'm good. Not necessarily, okay? So, like, that's the tricky area of refusals. And that's when you start offering the patient other options, right? So, okay, well, what hospitals do you want to go to? Or, let's go, just go get checked you out. Maybe something else is going on. I had a patient the other day, spent an hour on scene with her. She had 14 stents, cabbage times 2 or 3, and recently had just had another, and by recently I mean like 2 weeks prior, had just had another angioplasty where they opened up one of her stents, which had occluded. Extensive cardiac history. She's there like, yeah, I'm just, I'm having some shortness of breath, and I had a little chest pain. The chest pain went away, and she's laying there, and it's not particularly warm in her apartment, and she's sweating, right? She's glistening, and we're like, nope, you have to go. And we spent an hour convincing her to go, and she ended up needing, she was having another heart attack. It was an NSTEMI because her EKG looked fine. And, which we'll talk about what those terms mean when we get to cardiology. But she looked perfectly fine, EKG-wise. Her blood pressure was good. We sat her up. Her shortness of breath went away, but she was still kind of glistening. And, like, those are the clues where, like, you need to make sure that you convince this patient to go to the hospital. But but you also, if this patient didn't want to go, there's no reason that you couldn't call medical control after exhausting all of your options for trying to convince them, and have a doctor talk to them and say, yeah, like it sounds like you're having a cardiac event. So you have to know what your options are. You have to be kind of like a salesman or saleswoman, right? And be like a little bit suave, a little bit charming, and being like, no, listen, like, you really should go to the hospital. They're like, oh, well, there's COVID there. COVID's almost gone. COVID's off in one corner. You won't be anywhere near the COVID wing. You have chest pain. You have extensive cardiac history. We're going to bring you right to the chest pain center. You won't even see anything that looks like COVID. We'll even tell the giant foam virus that he's got to go stand outside so you don't have to pass him. So, like, just kind of, those are really important interpersonal skills that you're going to have to kind of work on and develop. And you're going to experience medics who are like, all right, cool, no problem, sign here, which is not necessarily the way to do it. And then, don't pick up bad habits, I guess, is the best explanation. But if you are going to RMA a patient, understand that make sure that they understand the ramifications of refusal, okay? They need to understand, like, hey, you might die. Like, there's a possibility that your condition will worsen. If they can be with someone who is another adult, okay, that's fantastic. If they have a logical plan for their continued care. Oh, I don't really want to go to the hospital right now. My mother's son, brother, sister called. I'd rather just go to my personal care physician and follow up there. Sure, okay. Patients have the ability to also just refuse part of the treatment, right? If they're like, I will do all of these things. You could do the 12 lead. You could do that. I'll take the aspirin, but you are not going to give me nitro because nitro makes me really sick. I'm not okay with that. Or most of the time it's needles. A lot of patients are like, do not give me a shot. I don't want the IV. And you're like, okay. But you do understand that, like, I might have to give you medications and then we're going to have to rediscuss this. And they're like, no, don't want it. No needle, drive faster. So just make sure that, these are all things that you document in the conversations that you've had with the patient. The patient also needs to understand the information that you're telling them. I had a crew once RMA a patient who spoke, quote, broken English. She was mostly Mandarin speaking. Okay, Mandarin's not in everybody's wheelhouse. However, what did you do to try to communicate with this patient appropriately? Did you call language line? Did you find a translator? Did they have a family member on scene who spoke better English? That was an RMA that I flagged. I'm like, this should not have happened. Like, if you can't communicate with the patient in clear language that the patient is 100% acknowledging, then they need to either be transported or you need to find a translator. Not okay, okay? Especially like if the patient's like, oh, I hit my head, but I'm okay. But I only speak Mandarin. But maybe they don't. Maybe they only, maybe English is their second language, Mandarin is their first, and they hit their head so hard that they can't English. Okay? I've had patients post-ictal who spoke English, but when they came to, were only speaking German because that was their first language. Okay? The brain does wild things. You should have a high index of suspicion for some of those things and not necessarily be quick to refuse or RMA a patient. Most of the time, you need to also make sure that it's signed. If you can have it signed by a witness as well. Depending where you work, a witness might be easier to find than other places. We'd like to leave patients who are refusing in the care of someone else, and that person should be the witness. And the patient should sign. There are situations where the patient may not 100% be able to sign. For example, the 93 refused all, right? Patient says, I don't want anything to do with you, and walks away. Okay, they're not going to sign. Or the patient who might have a touch of dementia and is no longer, the healthcare proxy is the one who is RMAing through telemetry, and telemetry approved it. That dementia patient isn't going to sign. Their healthcare proxy or whoever's making healthcare decisions for them will be the one to sign. So sometimes you have to kind of learn how to be a little flexible when it comes to making sure that all of these things are being secured. But then again, as long as you document it appropriately, you will be okay. We talked about this already, a reasonable plan of action for future care. And if there's anything that makes you somewhat uncomfortable about the patient was refusing to go, you should call it medical control, okay? Patient's having active chest pain and doesn't want to go to the hospital and you can't convince them, call medical control. Put that on somebody who has way more school debt than you do. They have better malpractice insurance. That's a them problem. Also, if you happen to treat a patient, and you'll see this in the city a lot, we very rarely transport diabetics who have been revived with sugar, because most of the time it's a simple issue. It's they took their insulin and then forgot to eat, or they've been a little sick lately, so they, their usual dose of insulin worked a little bit better than it usually does. Most of the time, this is like, it ends up being like a twofold process where you'll see experienced crews do it. They'll administer the sugar while asking the family to go get them a plate of food. They'll wake up, go, oh no, my insulin, and you're like, yeah, all right, let's sit up. How you feeling? You feeling okay? Yeah, I'm feeling all right. Get them into a chair, have them start eating, and while they're eating, you're doing a 3-lead, a 12-lead, another finger stick, and a Cincinnati and or SLAM score, because that's the stuff that medical control usually wants to see when you call to refuse this patient, because the patient very, very rarely wants to go, okay? They're usually like, no, this happens on occasion. I just took too much insulin. Narcan administration. Narcan administration, I usually don't even give them the option. What I usually try to do with Narcan is you ventilate them to get to the ambulance. You continue ventilating them until you're moving and then push the Narcan, just because those patients tend to relapse. Narcan only lasts about 20 minutes or so, and if they've had enough medication or drugs in their system, that they can go back down. So I try not to give them the option. But yeah, so and you're going to learn all these things, and your area is going to be potentially different than other areas, but you'll learn the quirks of whatever system it is that you're working in. This is a really good blurb that I've stolen and developed over the years from pieces of other people's ACRs in terms of what to document at the very end of a refusal. Mostly like the patient was advised of their potential risks and consequences of refusing care and transport. Most of the time you can add up to and including death. They were advised to follow up the primary care physician as soon as possible. Advised to call 911 if their condition changes or worsens. Patient signed the ACR and was left in the care of whomever, who also was the witness. And then paperwork was completed on scene and no further aid or assistance was requested. That's important. I like that one because for the most part, you'll end up finishing your documentation in the truck, but you're still sitting outside their house. So if something changes, they can come back out and get you, okay? And you can render care immediately. And I've had this happen once. We had this gentleman who had what appeared to be a very obvious GI bleed, hypotensive, tachycardic, vomiting up active like red blood, refused to go to the hospital. We spent 45 minutes on scene trying to convince him to go, and ultimately ended up calling medical control like, hey, he doesn't want to go. We can't get him to go. He's worried. He doesn't have childcare right now, and he had 2 young kids with him. He had I think his one daughter was like maybe 12, right? So medical control's like, all right, I guess you have to leave him. So we went back out to the truck, started documenting, and the daughter ran back out and was like, you have to come help him. He's not responding anymore. We went back inside, and there he was again on the floor, having syncopized because his blood pressure went so low. And we ended up transporting him. So staying on scene for just a little bit, you don't have to be there for like a half hour, but 10 minutes or so while you finish up your paperwork could mean, getting that patient care if they change their mind, or something worse happens.
Quick question for you
Go
based
ahead.
on that last call you gave us.
Yeah.
Would that be a second PCR, or would you just write that on the one PCR?
You write that on the same PCR. It would become a second PCR if you were cleared from scene and then reflagged. So because we hadn't cleared up yet, we hadn't given an available signal, we just advised we were reflagged for the same job. We're going to go back inside and get the patient, and then could continue the narrative. So we documented, like, we went back to the truck to finish, documentation. While completing documentation, patient's family member came out and said that patient had deteriorated, or status had deteriorated, went back inside, collected the patient and transported, and then here's what happens during that period of time. So it accounted for why we were on scene for so long, as well as why that RMA write-up turned into a transport. Good question, though.
Okay, awesome. Thank you.
Any other questions before we move on to the DOAs?
Did you keep the original RMA signatures or did you delete them?
Kept them. Because then in the billing side, they can just be like, well, the patient refused, but then the patient ended up being transported. There's a signature. That's good. Let them. Yeah, this also happens a lot. You'll call telemetry for a pronouncement on scene, and then the patient, like, the second you hang up, the patient will come back to life, and you're like, but you were just dead, and then you end up just transporting them anyway, and then usually they get pronounced in the hospital at the end of the day. So DOAs. These are easier because you really don't need to get a signature from them, and you really don't have to, like, confirm that they don't want to go because they have passed. But it is important for you to kind of do a clear documentation, especially if there's any potential that it might be a suspicious death. Okay, so who found the body and where was it found? Okay, so we had a suspicious death out in Howard Beach one day. The woman was cleaning out her mother-in-law's house, and she had what appeared to be kind of almost accidentally skateboarded on a folding table down a flight of stairs and broke her neck at the bottom of the stairs. Like, it looked like she kind of tripped and fell and, like, just slid right down these stairs on a plastic folding table. She had been there by herself, and I guess everyone was trying to get in touch with her and she wasn't answering, so her sister-in-law or something went over to the house and found her. Okay, there you go. So you have what happened, right? The patient was, here's the scenario. The patient was by themselves working on, cleaning out this house, and family hadn't heard from her in 2-3 hours. When the sister-in-law showed up, they found her at the bottom of the stairs, laying awkwardly. Akimbo. It's a great word. It's like when your limbs are all splayed out, akimbo. That's your SAT word for the day. So now, there you go. You have most of the qualifications of information that you need, right? Was the patient complaining of anything recently, right? So was it an accidental trip and fall down a flight of stairs that ultimately ended in her demise? Or was she not feeling well, had a heart attack, and fell down the stairs? Okay, so was it anything that the patient was complaining of? Was she on any medications that could have maybe caused her issue or her fall? A lot of the times you'll end up with patients who are, like, I guess I call it, like, peri-hospice, right? Like, they're very ill, they should be on hospice, but they haven't gotten to that point yet, right? So they might have a DNR, DNI, or a MOLST, where even though they've stopped breathing very recently, they're still considered DOAs because you aren't going to initiate any care. Was it a patient who was like, oh, I'm really not, a younger patient, right? Oh, I'm not really feeling well, I got like a head cold or whatever, I'm going to go to bed, and then never wakes up, right? So that could be the cause of their issue. Things that, if you're waiting for the police to arrive, because in the city at the very least, you need to leave the body with the police, and that sometimes can take a little while depending on where you are. I think my record for sitting on a DOA is 3 hours and 9 minutes. You need to document who that person is being left with, because it's now you're handing over custody of the human remains. But you can also start to prep the family, right? Once you're kind of familiar with the process, you could explain to them. So if it ended up looking sort of like a natural death, they need to collect the primary care physician's phone number. They need to collect their list of medications, a photo ID, all of those things for the police for when they get there. If there's a primary care physician who's like, yeah, like, this patient's been really sick, like, I'm not surprised that they passed, and they're willing to sign off on the death certificate, then they can pretty much call the funeral home, and the funeral home ends up coming and taking the body. If it's a 20-year-old who OD'd on, heroin, that's going to be an ME case. That's going to be picked up by the medical examiner. They're going to do an autopsy, and then the family's going to have to arrange for, funeral home stuff with the medical examiner. So just some things to take into consideration. Other great information that you want to try to include on different types of issues, right? With different like MVAs or falls and assaults. MVAs, right? We usually like to get how fast was the car going, or how fast was the car going that hit the car or the pedestrian or whatever, right? Because increased speed means increased deceleration, because speed doesn't kill, it's the decelerative forces that do. What did the car look like? If possible, I like to take a picture of the car and then show it to the trauma doctor. Like, this is what they were pulled out of, and it looks like, one of those compact cars that they crush into a cube, and they're like, oh, and you're like, yeah, because sometimes you can tell them there was significant damage across the car. There was like 2-foot, intrusion into the patient compartment, and they're like, I don't know what that means. And you're like, here. They're like, oh. You're like, yeah. So sometimes having that photographic evidence is helpful if you have a chance to do it. Airbag deployment, did it go off? Did it not? Sometimes airbags don't go off when you expect them to because it just didn't hit the sensor quite right. Spider webbing. I had a gentleman once who was so large, in so much as he was like 6'6" and like 300 pounds, in the front seat of a RAV4, that even though he was wearing his seatbelt, he still managed to hit his head on the windshield because he was just too damn tall. So he had a head injury with spider webbing despite positive seatbelt and airbag deployment. So, just details that you should add because it gives a really good information for the trauma team for what they need to investigate. Helmets are always important when especially kids riding bicycles. Kids riding bicycles, you also want to ask about whether or not they went up and over the handlebars, right? We talked about this a little bit, about how kids have not the strongest abdominal walls. So if they go up and over and they hit their abdomen, you have a chance of a liver injury or a spleen injury. So they could be bleeding internally in a significant manner that you won't necessarily notice right away. Falls, right? How far did we fall? What did we land on? Because landing on soft, squishy grass is going to be a lot nicer than falling on concrete. Did we hit anything else en route? The ongoing joke that you fell out of the ugly tree and hit every branch on the way down. Kind of sometimes, you want to know what they hit. Assaults, what were you assaulted with? Hands are going to kind of create different injury patterns than a weapon will, because your hands get beat up way faster than a hammer will. So you're not going to necessarily continue wailing on someone if you've now destroyed your own hands. And the size and weight of the assailant also can create different, if you have a smaller person who's beating up or beating on a larger person, they're not going to make as much damage as a larger person beating up on a smaller person. Other fun things, impalements, amputations, and shootings, right? You want to document any relevant information there. Things that you also need to make sure that you you document carefully. Get stuck there. Most of the time it's extended times, okay? Like, why did it take you so long to get to scene? Why did it take you so long on scene? If you spent an hour on scene with this patient, why? Well, we spend a lot of time convincing the patient to go to the hospital. We were doing CPR, and every time we got ROSC and went to package, the patient went down again. Or it was a difficult extrication. The family intervened and didn't want to let us off scene. The train, right? A lot of different things. And equipment failure, right? Did you have to call? I had this job once. We were transporting this sweet lady, elderly lady, kind of, vague complaints. Taking her to the hospital. We go and the truck stalls out. We're like, okay. Well, we need another unit to come transport her. So we had to call for another unit to come take the patient out the back of our ambulance and continue the transport to the hospital. And that ACR ended up being a 94, which is a unit-to-unit handoff. And it did this, and this for the patient. Did this. Truck stalled. Called another unit. handed off to this unit, they continue the transport to the hospital, right? So sometimes you have to account for what happens for you. This is going to be important, I think, for you guys, because this is all the new stuff that you're going to start learning and all the things that you're going to have to document. People always ask me, oh, where do you put the ALS skills in with your documentation? And for the most part, I'll do my objective, what I saw when I got on scene, what the patient was complaining of, so it's a little spicy little dash of subjective, right? I'll do my, as I like to call it, my scene description. So it's about a paragraph worth of information of where I found the patient, how I found the patient, what they were complaining of, or anything else that's important, right? State of the house, state of the family, maybe the family's panicking and delaying patient care. That's my little summary. And then I do my little physical exam paragraph. I usually start with age of the patient, how old, I just said that, how old the patient is, ABCs, airway patent, breathing, and I do my ABCs up top, and then I do my full head to toe kind of physical exam with any pertinent findings. And then after that, when I usually conclude it with no trauma injury noted, then I'll go into what else did I do. And this is different for depending on what kind of patient care is being rendered. So for example, if I ended up tubing the patient, airway information is going to go up way earlier. But most of the time with most of your general patients, when you're just kind of documenting that you've done a cardiac monitor and IV and or medications, I kind of throw that at the end. So you do your physical exam and you've kind of noted that you've looked at the whole patient and you've concluded that this is what's wrong with them and I'm going to move forward in this care. Then I put the 3 lead was sinus rhythm, 12 lead had no elevations or ectopy, or I'll put patient was defibrillated at 200 joules biphasic, or we cardioverted, and then also that I've documented that I've gotten an IV and or tried and failed to get an IV, and what gauge it is. So that kind of goes just for me towards the end. And then also very important, how much fluid was given. This is essential for a lot of patients. So if you do decide to run fluids on a patient, make sure you very carefully document how much. This has come up in a lot of sepsis protocols, right? They want to know how much fluid. And when you get to, I've actually had an ER physician ask, hey, can I see the ACR for this one patient? Send it to them, and they're like, this is fantastic. They've clearly documented how much fluid was going in. It really helped make patient care in the future, consistent. Golden, okay? Everyone's happy.
So why, if you said earlier, you want your flow chart to match your narrative, why do you put your IV and stuff all at the bottom? Why wouldn't you put that in the same continuum that you do,
So
patient assessed, blah, 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 at that time inserted a 20 gauge IV in his left AC or something, and then...
Yeah, so there's 2 ways to do it. I like to do it at the end because it kind of gives you the idea that, hey, I've asked the patient if they have any allergies. I've asked the patient all these questions, and the reason that I'm doing an IV and a monitor is because I've concluded that through my physical exam that's why. When I say make sure that your flow chart and your narrative match, I mean in so much as that you put everything in your flow chart down into the narrative as well. So if you're
times wise.
Oh no, times wise, they should match sort of.
Right.
Most of the time, I don't document times in the narrative. If you want times, go to my flow chart kind of thing. Cardiac arrests are a little different. I'm actually going to kind of just show you some examples actually coming up really soon. But basically, if you did an IV, it should be in both places. It should be in the narrative and in a flow chart, because I see a lot of people, they do it in one place and not the other. And that's, to me, inconsistent and is kind of sloppy. If that answers your question. So kind of moving on from that, building off of that, be consistent. So whatever you decide that you're going to use, whatever method you want to use, stick to it, okay? And that could be hey, I always document this no matter what, or it could be I document this way unless it's, a cardiac arrest, or I always document this way unless it's an RMA, and then I add stuff or I take stuff away. So different methods that you can use, and again, you can kind of fit in your ALS treatments in different spots if you'd like to. I'll show you the chronological method is usually what I use for cardiac arrests, just because you're not doing a really significant physical exam. Your physical exam is they're pulseless and apneic, and I've started CPR. So in that case, it'd be like, okay, we started CPR, and we'll get to that in a second. But your chart method is your chief complaint history, assessment, RX for treatment, transport, and any exceptions. So what you didn't do and why you didn't do it. Didn't give patient an IV because they refused. Please see, they refused with signature. Versus your subjective, this is pretty much how I personally document. Okay, so you start, what did I see when I walked in the door? How is the patient seated? Was the patient laying on the floor? OPQ, STI sample. What did you find during objective, right? So anything that you've during your objective assessment. What did you find that the patient says is going on? Okay, the patient says they're having chest pain. On the 12 lead, we found elevations. And then what's your plan of treatment? Okay, so the patient was having chest pain, so I gave them aspirin. I gave them aspirin successfully. They chewed it. There was no change in patient's chest pain. Gave the patient nitro with positive effect to their chest pain from a 8 out of 10 to a 6 out of 10. And then we transported. While en route, we called telemetry and got something else because we were feeling fancy that day. So it's kind of, you want to make sure that you're painting a full picture. This is the head to toe is really good for patients who have been a trauma patient. You basically do the same thing, how you found the patient, and then you pretty much document your head to toe that you would do in your BSIC safety, MOI, NOI, right? That your BLS vibe. So this is, when I write my ECRs, it's a combination of the SOAP method. So I'm writing a really solid subjective and objective assessment, and then I do a head to toe. Because sometimes you'll find stuff in a head to toe exam that's a medical head to toe, right? So a patient might have ascites, or the patient might have a pacemaker, or a patient might have pedal edema, right? So these are just things that I like to throw in. In my head, it's easier to remember head to toe, because when I was an EMT, I was taught if you document everything head to toe, it's harder to forget something. You're not wrong, right? So you're following the head to toe exam. If you've passed it and touched it, you document it. So I've kind of just built off of that. Also chronological. This is we arrived on scene to find a patient lying on the floor. Family says that they haven't seen the patient in 2 hours. Upon arrival, patient was found pulseless and apneic. CPR, high quality of CPR was initiated with high quality chest compressions allowing for full recoil. Patient was ventilated with a BVM and a BLS OPA. And then you just go from there, what you did. Patient was administered epinephrine 1 to 10,000 at 9:52, 9:55, and 9:58, right? These every 3 to 5 minutes. So you can document that. In that case, if you are documenting times, which is in I only do that in cardiac arrest, documenting medication administration times is the only time I document that in the narrative. Make sure it matches with your flow chart, okay? Fun thing, knowing your equipment, your life pack, if you happen to be using a life pack, because I'm not super familiar with other monitors, there's an event button. So if you give a medication, you can hit the event button, and it will you can document which medication you've administered or just put a generic event in, and it will timestamp it for you. So when you upload your code summary to your Health EMS, it will have everything timestamped, so you don't have to put the times in. You just have to document what you did. It's a little helpful when it might get a little chaotic on scene. There you go. As I said, your event button. Know what your equipment can do. It's super helpful, but sometimes it's not always practical. Sometimes your monitor is not within arm's reach. Please don't document that the patient had negative decap BTLS. No one knows what that is except for EMS people. I like to say, I like to just say that the patient has no signs of trauma or injury noted. If you're not sure, check or just use plain language. Patient had deformity to their limb or lower arm or whatever, right? You don't necessarily have to use words like crepitus or whatever, as long as you are documenting that there is something wrong there. All right. Any other questions about documentation? Pretty straightforward. If you ever have any questions about documentation, please throw it in the group, bring it up in class, and we'll we'll clarify it a little bit more. When you start doing your ALS rotations, ask to read the ACRs of your preceptors. A lot of them will be like, sure, here, no problem. Some of them are like, no, because people are weird. So just, it's good to see a lot of different options when it comes to writing, because everyone has a different style. And I'm sure you've already developed a style yourself, since you all have experience as EMTs. So, you know, can you add? How can you build on what you already have? Take a quick 5-minute break, stretch, bathroom, more coffee, and I'll see you in a minute. Come on, share. Boom. All right. I don't know where the little dinosaur came from in the top corner. It's fun, though. So medical terminology. So we have our own kind of language when it comes to medicine, and that's important. A lot of those root words and stuff are going to help you when you're figuring out what's going on with the patient or the medical history. Most of the words that are referring to diseases are from the Greek, while most of the words referring to anatomic structures are from Latin. This is kind of just based on who was doing what back in the day of, hi Bubby, of like, you know, who was, you know, the Greeks were all like, we're going to define this disease. Let's drink this urine and see if it's sweet. Thank you. Enough. Other names happen to be after people, right? So Parkinson's disease was named after the doctor who identified or described it. Alzheimer's, Dr. Hodgkin, right? Hodgkin's lymphoma. Down's disease, or Down syndrome. Other things that you have to kind of be aware of are that we also kind of apparently ran out of words at one point when we were deciding to name things. So you have some homonyms that do exist, right? So words that sound the same but might be pronounced differently. So you have the iliac crest on the ilium bone, which is in your pelvis. And then you also have the ilium, which is part of your intestine. Dysphagia versus dysphagia. I don't know who this is. Hold on one second. I have to put my professional voice on. Hold on. NYU EMS, Nicole speaking. Silence. Not even my car's extended warranty. Right, so they might mean different things. You should kind of understand like the different word roots, right? So a lot of the times we do happen to know things like dysphagia or dyspnea means it's not good. And U is the opposite of that, right? So eupnic, if a patient is eupnic, they're breathing normally. Dextro versus sinister. Dextro is right, sinister is left. Long history of that root of the word, because people thought left-handed people were the devil, so they were sinister. Ad versus ab, right? So if you were doing adductors in the gym, you're bringing it closer, where abductors, you're taking it away from your body, like an abductor, person who kidnaps, right? They take that child away from their parents. When you have synonyms, which are word roots that kind of mean the same thing, so probably the easiest are the ones that are here, like pulmo or pneumo, right? That's both lungs. Cardio or coro is heart. Nephro or renal, right, is your kidneys. So kind of being familiar with the origins of these word roots will help you when we start doing diagnoses and stuff like that. When you're putting together a medical term, it'll be the prefix, which might be like, dis, or right. That's, wow, blanked on that one. Like dyspnea, right? So the dis was the prefix, pni is the word root, and then a suffix, and that ends up being the medical term. Sometimes you have to add vowels in there, and this is where people start to kind of have issues when they're not 100% familiar with what the word might mean or how they're going to build the word. If they're trying to use their fancy medical terminology in their ACR, you don't necessarily have to use it. You can use simple plain language if you're not sure. All right, so here's some colors that we commonly use in medicine. The top 4, probably the most, or 5, right? Cyano for blue, for cyanosis. Leuco, white blood cells, right? Leukocytes. Erythro is red, erythrocyte, red blood cells. Cirrhosis, or is like yellowish. And then melano for black. You also have chloro and alb, but we don't really, at least in the emergency medical field, we're not really using those often. Different planes of the body. This is another thing I always have to recheck before I look or teach, because I always get it like a little bit wrong, which plane is which. So you have your transverse plane, which cuts you up superior and inferior. You have the medial plane, which goes down left and right, and then you have the I think that's the coronal. No, sagittal plane, and then you have the coronal plane, which goes through front and back, or anterior and posterior. You should kind of have a general idea of what these planes are, because if you're going to be describing where an injury might be, it's going to be important to kind of understand it. The more common, I want to say, is probably the use of medial lateral, right? So medial, it's inside, lateral, it's out, like away from the core. Proximal versus distal, right? Distal is at the tip. Proximal is in the up close. Or anterior, posterior. Inferior, superior is also potentially more common and helpful, right? So inferior is above, or inferior is below, and superior is above. Just some terms that might help documentation, or even understanding documentation a little bit easier, right? So if you happen to be doing like a transport or interfacility, and you have, you're reading a patient's medical record, you might see a lot of these words. If you're ever reading an MRI or CT, you're going to see the sagittal, frontal, coronal plane probably a little more frequently. Our body is divided into body cavities. This is primarily in your torso region, right? So you have, but it's also up in your head. The dorsal body cavity is that anything that contains your brain and your spinal column. And then your thoracic cavity, right? Whatever contains your lungs and your heart. So you have your lungs are kind of in their own little space where they have their own pleural cavities. Then you have the mediastinum, which contains the heart and the great vessels, as well as the esophagus and part of the trachea, right here in the middle. But then inside the mediastinum, you have the heart, which is also surrounded by the pericardium, right? Because it needs to keep it protected as well. There is a small amount of fluid inside the pericardium. It's about 10 cc's. That helps lubricate the heart, because as the heart beats, it actually swings back and forth. So it's surrounded by a little bit of fluid so it doesn't get hot. Think of it sort of like a car engine, right? We put oil in there so that it doesn't seize up the engine. But too much oil is not a good thing either. Then you have inside you, or lower, you have the abdominal cavity, right? It contains all of the important organs that we have. mostly your intestines and such. You have the retroperitoneal cavity, right, which is in the back and contains your kidneys. So different body cavities kind of will then help sequester blood and prevent blood from spreading from one cavity to the next. So if you have a patient who has intra-abdominal blood, that's not going to necessarily seep up into the pleural cavity, right, because it's separated by different things. So you want to just make sure that's you understand what the different cavities are. Another way for dorsal and ventral, if you're having a hard time kind of remembering, dolphins have a dorsal fin, which is on their back. So dorsal's back. We talked about all of these already 2 slides ago, so we should be good. You should also kind of understand supine versus prone. Those are important in terms of positional. Palmar and plantar. Okay, so palm, plantar fasciitis is the bottom of your foot. So just understanding where those things are helps kind of help position you in time and place. You should kind of also be familiar with how the body moves. For example, knees shouldn't bend like that. That's a bad day. Range of motion is the full distance that a joint can be moved. And this is also very much dependent upon age, like lifespan, because, for example, babies have a different range of motion than adults because their joints haven't actually joined together yet. They don't even grow a patella until they're a few months old. Okay, that's why babies can crawl around on the floor and be in zero distress, and meanwhile, as adults, you like kneel on the floor and you're like, I've died. They don't have patellas; those grow in a little bit later. So older people are going to have less range of motion, but potentially have less range of motion than younger people, right? Then there's some young people who don't have great range of motion. Most of them are here in EMS because we've destroyed our backs. Hyper is when we start talking about range of motion beyond the normal, okay? And this is like the people, like everyone knew this kid in high school who could like hyper extend his elbow or like his shoulder or whatever, right? Most of the time his elbows, like you would go like this and the elbow would go pop, right? Or if you see people who stand and when they stand there, like their knees look like they're going the opposite way, that's hyper extension, okay? That just usually means that they have a muscle imbalance at this point when you get to our age, of older than 18. But you could do a whole number of things. If a patient's sitting there and their range of motion is wild, it'd be like, sometimes people are like ballerinas or gymnasts, and they have wild range of motion, okay? Not always 100% pathological, but usually that's why we're being called, is because they moved beyond their range of motion and something went wrong.
They're called like a contortionist, right?
Exactly. So those are the people who they have a normal hyper range of motion. But for them it's normal, but they've trained their body to be able to do that, right? That's a lot of stretching and a lot of muscle training for them to be able to extend that range of motion. I hear dog toes. Other things that they kind of want you to know is supination versus pronation. Pronation is usually spoken about really in just your feet and or your hands. So you're going to pronate, which is you're turning it down, right? So pronation in your foot is that it's collapsing down into the arch, which is, they talk about people who are runners. Oh, you're a pronator. Okay, it means that you're not keeping your foot neutrally; it's collapsing in. Or you're a supinator when you land and your foot tries to raise itself up, right? So supination when you're raising it up. Internal rotation versus external rotation. We talked about that briefly, right? So how is the limb being moved or rotated? Different terms that we talk about when it comes to movement and position. Bilateral obviously means both sides are affected. So we talk about unilateral, we usually like stroke, right? Cincinnati stroke scale, like unilateral arm drift would be just one arm. If you have like a bilateral injury, it's occurring on both sides. Ipsilateral is on the same side. So most of the time when you have a patient who's having a stroke or something, there's a contralateral issue, which means that if they have an ischemic issue on the right side, that their left side will be affected, right? They'll have left-sided deficits. Contralateral, on the other hand, is on the same side. So, for example, if you have, you see this a lot with cranial nerves and spinal nerves.
Nicole, ipsilateral.
Yes. What about it?
No, you said contralateral, then you were saying on the same side.
Yes. Thank you. Ipsilateral is the same side. Contralateral is the opposite side. Thank you. So ipsilateral would you usually see with cranial nerves and spinal nerves. So there's an injury to the nerve and it's affected on the same exact side. So if you have a patient who has like an optic nerve injury, it will be on the same side. It'll be ipsilateral. Contralateral, opposite. Thank you. We discussed the abdominal region already, but here's another quick review. We can, beyond dividing the abdominal cavity into 4 quadrants, you can then go and divide it into 9 and play abdominal tic-tac-toe. Whereas in the middle you have the periumbilical region, right? So that's going to be, if you have any sort of issue, the Cullen's sign, okay, which is a great sign for a ruptured appendix. But you have the left lumbar, right lumbar, the hypochondriac regions, and the iliac regions, okay? Hypogastric is usually associated with menstrual cramps and or bladder problems, okay, depending on gender. Iliac regions for females is kind of where you'll see patients experiencing ovarian issues, ectopic pregnancies, etc. If you're going to use abbreviations, make sure something fell. Make sure that you are using appropriate abbreviations, ones that have actually been are approved and universally known. So there's some nursing abbreviations right here. We can't necessarily this is useful if you're ever using handwriting, a handwritten, whatchamacallit, signs and symptoms. This is helpful. Prescription, SX is great for surgery, diagnosis. You can put your treatment section here for the TX. One thing that I'm going to say is make sure that if you are documenting medications, never ever use what we call trailing zeros. So if it's you're administering a patient 125 milligrams of Solumedrol, it's not 125.0, because sometimes that little decimal point gets lost, and then you've administered that patient 1,250 milligrams of Solumedrol, and people have a panic. The same thing though with smaller dosages, right? So epinephrine, right, is 0.3 milligrams of epi 1 to 1,000. Put that 0 up front so that decimal isn't naked, because the decimal can get lost. There's no other reason that you're going to put a 0 in front of a number for a dosage other than that it is a decimal place. Okay, so just make sure, because that kind of signifies to people like, hey, this is here. Say that again, Vinny. It doesn't matter. What does the 0 not matter? It disappeared on the chat before I could read the full thing. All right, moving on. Oh, good.
Vinny, you're muted.
There we go.
All right, I'm here now. Hold on. Just scroll down to the chat. Yes. Yes. So if you are doing drug math, you don't have to put the 0. You just need to make sure that you know how many decimal places you're moving the decimal over after. The 0 in front doesn't count as a decimal place, so you're just reducing the number of numbers that you're putting in there. But when you are documenting, you need to make sure that that decimal isn't naked, because it will get lost, especially if you are, for some reason, still on a handwritten system. That's why that kind of came into play, because people will be like putting in decimals and it looks like a comma, or it looks like a errant ink smudge, and just not doing what it needs to do. Questions, thoughts, concerns? Ow. All right, cool. Forward motion. So, pathophysiology, this is kind of our bread and butter, right? We don't necessarily get called to things that are going great. We get called to things that aren't going well. But we need to kind of understand some of the background of pathophysiology when it comes to patient care. So, one of the number one ways that your body tries to adjust to non-perfect states, let's put it that way, is that it will adapt cells. So, for example, you might have a normal bronchial epithelial cell. If you happen to smoke, it might cause the cell to have metaplasia, which means it changes the shape and the function of the cell. Okay. You could also have a patient who has like cystic fibrosis, where maybe they have hyperplasia and they have too many cells producing mucus. Dysplasia, the cells, if you kind of see it's the cells formed all wrong. It's just not right. Like here, the normal epithelial cell, it's got the little cilia on there. It's got these cell bodies. This one doesn't have all of the things that this normal cell does. And then yes, most of the time we talk about, when we talk about atrophy or hypertrophy, most of the time when we use those terms, we're talking about muscle cells, like I guess in common language, right? So hypertrophy is that guy who's at the gym who's like, I've built up all these muscles, bro. So right there, you're training those muscle cells to become bigger and stronger, and then you stop going to the gym and they start to shrink. All right, and they get smaller and they atrophy. Atrophy is usually caused by underuse, and that underuse could be, oh, you don't go to the gym, right? You don't exercise, or it could be, oh, you've been paralyzed and you no longer can communicate with those cells in your body, so those muscles start to deteriorate. Okay, just different ways that the body tries to adapt for its state of being. For the most part, we as humans are giant cucumbers with emotions. We are almost, depending, about anywhere from 75 to 50 or 50 to 75% water. Okay, everything else in there is just bonus material that gives us structure and makes us a little less cucumbery. One of the initial things that you should think of if somebody is having an issue, especially in the United States, is that there is some sort of water imbalance. Most of the time it's dehydration. Okay, as I sit here with my 40-ounce water jug, a lot of the times people do not drink the amount of water that they really need. That whole 8 cups of water a day thing is kind of a low ball. Your body functions really much better when it's well hydrated. But sometimes it's hard for people to do. Especially in the United States, we have so many options for different things that we can drink. You know, sugary drinks, caffeine, all of those things kind of dehydrate us and don't necessarily contribute to high levels of hydration. I don't know if anyone else is like a water fiend like I am, but I know if I don't get enough water during the day that I feel crappy. Like I just get tired, I'm kind of run down. But if I make sure I keep my water intake up, I feel fantastic. It's great for your complexion. But yes, so if you have water imbalances, you also have electrolyte imbalances. Salt follows water, okay? So if you drink a lot of water, the salt will go with it, so you might have lower sodium. However, the body is also really good at kind of keeping you in this really tight range of your electrolytes if you're healthy. Some of the issues that you do kind of see is when patients overdo it. In terms of water, like you'll see this, there's people who have died at the end of marathons and such because of water toxicity, where they drink a gallon of water really fast and their body's like, whoa, and they flushes the salts right out of their system. It causes cerebral edema. Not a good look. Will kill you. Dehydration will kill you before starvation does. If you don't drink water, it will kill you within 3 days. It takes about 3 weeks to starve to death.
Oh, yeah.
So, just some things to keep in mind, okay? As you get older, you don't.
Go ahead. I'm in class, but
Oh, I'm sorry.
that's okay. I can talk.
Beth, you mute. Beth, mute.
I just talked to this one dealer.
As you get older, you have a harder time maintaining good fluid balances because, for example, you might be on diuretics, right? So you're urinating a lot. As you get older, your sweat glands actually decrease. They stop. You start losing sweat glands, so you can't sweat, which means you can't control your body temperature as well. Your kidneys start to lose as much vital function as they used to have. So some issues there. Children are like 75% water, right? The most cucumbery of humans. So they will show signs of dehydration a lot faster than we will. They're smaller. They're a lot more water. So if they're low, they're going to get lethargic and kind of grumpy way faster than we do. And you don't think about giving kids, water like they have, especially little babies, right? You give them a bottle. They actually say like don't give young pediatrics water. Because it's like the really young ones, like a bottle of water, because it can be too much for them. So they have to they are still figuring out homeostasis. There you go. 6 liters of water can kill a 165-pound adult. So if you ever want a nice way to take somebody down, just hydrate them to death. But again, this isn't a short period of time. It's not like 6 liters over 2 days. Like that's not going to do anything. But it only takes 3 to 4 days to kill the average adult without the right amount of water. So going on with water, the water theme, edema is what happens when you have increased capillary pressure that pushes the fluid outside of the blood vessels. This is also why we don't for example, why we don't take blood pressures on breast cancer survivors, right? Who've maybe had a mastectomy, because they often take the lymph nodes out on the affected side. What happens when you have your blood flow? It goes through your veins, it goes through your arteries to your arterioles to the capillary bed. At the capillary bed, you do have a certain level of loss of plasma into the interstitial spaces. In those interstitial spaces is where that plasma gets picked up by the lymphatic system. The lymphatic system kind of filters it out. It's like, whoop, this is no good. This is a bacteria. Go away. And then as it comes back, it drains back into the capillaries. Okay. If there's some sort of obstruction in the lymphatic system, you're going to end up with edema. If you have excessive amounts of fluid being pushed out of the capillary bed, like taking a blood pressure on a mastectomy side, and the lymph nodes are no longer there to push it back into circulation, you're gonna have edema. And this is also what you see when you have patients who are, CHF, right? So you have this high pressure in the system, the overall system, and it fluids, the plasma starts to leak out into the area around the cells and just creates the edema. Edema is also totally normal. When I ran my first ultramarathon, my hands blew up from edema because I wasn't really using them, right? Because you're just running like this. So my hands swelled up, my feet swelled up. It's very common at the end of the day, just from the different pressures. Also, if you have decreased colloidal pressure, right? So if the contents of your blood are not enough to pull that osmotic pressure, right? Because pulls the water into the bloodstream, you'll have some losses to the interstitial space. So, we also see edema in the lungs, right? Acute pulmonary edema, CHF edema. Most of the time, when you're assessing for it, you want to make sure you get a good set of lung sounds. I know a lot of the times when you're doing your ABCs, when we teach you in EMT school, we teach you to take the top 2 lung sounds because you want to make sure that air is going in and out. As you start to kind of transition into like paramedic, we like to see that you get good sounds at the bases. If the patient's awake and alert and talking to you, and you can kind of judge the fact that they're breathing adequately enough to talk to me. But if they're having shortness of breath and you don't have any like stridor, right, where you might have an upper airway obstruction, you want to get good bass sounds because maybe their shortness of breath is being caused by pulmonary edema, right, of CHF kind or the emergent APE kind. Other things you want to check, always check a patient's ankles. Sometimes checking their sacral area if they're like sitting or their ascites area is a little awkward, but you can ask them if their stomach always looks like it is or they feel like they've got weight gain around the middle, because that could be just fluid. JVD, often a late sign, right? You'll see these veins popping out because of this backed up pressure. But when you're treating this in particular, CPAP is great. These are the patients who they want to dangle their legs over the edge because they're creating increased areas, gravity-dependent areas, for that fluid to escape. Okay, these are patients who are not going to want to sit back. Diuretics can be helpful, but it's often that it's often a longer-term kind of thing. You won't see that take effect right away, whereas CPAP you will. It'll take place right away. There's different managements for different APEs, but you're going to look at your protocols for those when we get to that point. Nitrates are also super important. It increases the size of the vasculature and allows the fluid to kind of replace itself into the intravascular as opposed to interstitial. Most of the time when we talk about fluid disturbances, it's either you have too much or not enough. If you are in the deficit, most of the time it's brought to you by sweating. It also can be brought to you by lack of intake. Okay, especially the elderly, they start to like lose the impulse to drink water, so they don't drink as much, or they're on diuretics and they don't want to go to the bathroom all the time, so they really don't drink water, but it's still pulling fluid off of them. You'll see that they'll be here in this dehydration deficit area. Very common. These are the patients who, if they sit up too fast, they might get dizzy. They have stopped producing urine or as much urine, so they're, this is kind of the traditional symptoms that you'll see. As opposed to a patient who is in fluid overload or excess fluid, they will end up having a lot of kidney issues, right? Like they're trying to put out too much, they're trying to put out all this urine, but there's too much fluid and it backs up into their heart, into their lungs, so they'll have congestive heart failure. These patients also might have sodium imbalances, right? Because wherever water goes, salt goes. So if you have a lot of water, they're going to start retaining salt as well. When you're thinking about electrolyte imbalances, and we're not 100% at that point yet, but we're going to start talking about some of these things. If you have a patient who you suspect has like a sodium imbalance or an electrolyte imbalance, most of the time sodium has to do with the central nervous system. Okay, so they're going to be delirious or unconscious. They might be having seizures, depending where on the spectrum of too much or too little sodium they have.
I very funny story. But back in the 90s, when I first started working, I was working with a team that we were deinstitutionalizing the psych hospitals, the institutions that were housing developmentally disabled and putting them in community homes. And we had constant issues with people becoming hyponatremic because they had never in their entire lives, these were 50 and 60-year-old people, been able to drink whenever they wanted. And so they were drinking so much that we kept having to have them transported to the hospital because they were hyponatremic, and they became like, you're talking about people with psychiatric issues, developmental delays. So being altered was sometimes tough to see, but then all of a sudden it was just like over the top.
Yeah.
And it was just an interesting.
That's a fantastic.
Interesting
yeah, that's a fantastic story, because like honestly, like you're right, like people who are institutionalized, even nursing home patients, right? It's hard for them to get water, which is just out of control if you really think about it. Like seems like such a basic human need. Like, nah, you can't have that. And now they have that freedom. Wow. So some general numbers you should kind of be familiar with. There will not be a quiz on this. Sodium, and if you ever go get your physical, like you all had to get a physical to to come to medic school. So feel free to look at these numbers and see where you fall. You should, I'm hoping, all be within the same range or good ranges. Your sodium is between 136 and 144 milliequivalents per liter. So if you have too much sodium, you're considered to be hypertonic. You have more water loss than sodium loss in your system, as opposed to when you're hypotonic, which is less than 136, you will have more sodium loss than water loss. A lot of the times hypotonic or hyponatremia can end up with patients having like seizures and stuff like that. But they also can kind of present with being nauseous, vomiting. A lot of times when you're on the hypotonic side, it's caused by like sweating, especially you see this in the summer a lot. We can, if we do not watch our IV fluid administration well, we can cause this as well because you're flushing out a patient, putting them into fluid overload. When we talk about cardiac dysrhythmias and stuff in the future, sodium is the most commonly found extracellular electrolyte, right? So this is what's floating around outside of your cells, whereas potassium is the most common intracellular electrolyte. And this is that difference between sodium and potassium, and those is really what fuels your heart's automaticity, and it also is what fuels how your nerves work. Okay, so those are things that are important to kind of understand when we get into cardiology. Potassium is one of the most potent electrolytes, especially when there's too much of it. Too much hyperkalemia will potentially put a patient into lethal cardiac dysrhythmias. That's your VFib and your VTAC right there. Most of the time, hyperkalemia can be, while it can be caused by dietary intake, it's usually secondary to some sort of significant traumatic injury that's now rupturing the cells, right? So if you have sustained burns or some sort of crush injury, that potassium is going to leak out of the cells. This is also, hyperkalemia is like the #1 electrolyte imbalance that you'll see in nursing homes. If you ever seen like those little LabCorp cars driving around, they go from nursing home to nursing home, they draw bloods for every nursing home, they go back to the lab at the end of the day. So those cars, right, they're bouncing those blood samples down the road, are breaking up those little blood cells and releasing potassium into the serum. So when they go and test those bloods, it's going to show potentially lethal doses of hyperkalemia for patients, right? Because it was fine when they drew it, but then it sat in a car all day and those cells started to break down. And now all of a sudden grandma should have been dead, 2 days ago because she has a potassium of 10 and it's not compatible with life, and they're sending her to the ER, and the ER doctor's like, but why is she here? I don't understand. Hypokalemia, you'll see this a bit with patients who have just gotten off dialysis, right? Because potassium is very dangerous for those dialysis patients. So they're the ones who they will take the potassium off of them. So right after dialysis, they might feel muscle cramps and muscular fatigue and weakness, right? Because they live maybe a little bit closer or just above this 5 range for potassium. And now they've cleaned the blood up and they put it back in, and they're back down here at the 3.5, and they're like, their body needs to change. It's called disequilibrium syndrome. Their body's trying to adjust to like fresh, clean blood. You see that very commonly right after dialysis. Patients will have like muscle cramps. Totally normal. Calcium. Calcium is also highly contributive to the cardiac cycle. The calcium is what actually gives those muscles their contractility. When you see patients who are in hypocalcemia, you might have, again, muscle spasms because their muscles can't coordinate effectively. Where you're going to have hypercalcemia, you can see a lot with cancer. Cancer will end up leaching the calcium from the bones. Radiation Radiation also does something similar, but that ends up over here, usually the hypocalcemia side. It leaches the calcium from the bones and then like out of the system. Patients who have hypoparathyroidism will have low calcium levels because they're unable to regulate. The parathyroid actually regulates with calcitonin, an enzyme or a hormone, will regulate how much calcium's in the blood. So if they don't have enough of the calcitonin, the body can't figure out how to balance that well. Increased calcium intake, the most common cause of this is over-the-counter antacids. There's a lot of calcium in those. Phosphate, we're not going to talk about this really significantly. They check for it. It's not seen a lot, but if you have patients who have decided that they're going to give themselves laxatives and stuff, they might have too much phosphate. Bodybuilders or people who are doing heavy dieting when using laxatives and enemas to try to get weight off. Random, again, a lot of central nervous system symptoms that you might see. A couple cardiac, a prolonged QT is a cardiac issue. Rhabdomyolysis, the muscle breakdown, not high on my list. I'd make sure that you know the differences between sodium, potassium, and calcium. Magnesium is also not super important, but you should kind of have an idea. Magnesium is really hard to get out of range. Your body's pretty good about maintaining it. We do not get a lot of magnesium in a diet, but it's often something that if you supplement, your body's just like, nope. The number one way that you can determine if you are in fact supplementing with magnesium, which is great to help reduce muscle cramps and improve relaxation, especially if you're having issues sleeping. Magnesium is usually a good over-the-counter thing. You can tell that a patient is has too much or has the right amount of magnesium when they start having loose bowel movements, because it's moving the peristalsis along a little too quickly. All right, acid base. This is important. Your normal pH that you see in a human body is between 7.35 and 7.45. When we get to end tidal, you're going to see that the normal end tidal that we for a human is 35 to 45. It might be a little bit aligned. These are numbers that you should kind of understand. Neutral, when it comes to between being an acid or a base, is 7. Okay, water. Water is neutral. Water is 7. So we live just a little alkalytic. Okay, just a little, just a smidgen, not too much. Right, so acids in our bodies are hydrogens, okay, and bases are bicarbonate, okay, with the OH. When we go through the respiratory cycle, when you breathe in oxygen. When it gets down into your cells, it's that oxygen swap with carbon dioxide. Carbon dioxide is transported in the blood as carbonic acid, okay? So when we talk about, the patient's blowing off acid, they have excess carbon dioxide that they're, right? So they also could have excess acid secondary to metabolic or metabolic causes, right? So patient who's in DKA, you'll see, right, they have those Kussmaul's respirations where they take deep breaths and breathe really fast and they're trying to blow off the acid. Respiratory is the fastest way that the human body can try to adjust to acid-base imbalances. Most of the time is caused by potassium, which you see in DKA, but it also can be caused secondary to respiratory issues. For example, cardiac arrest. That patient's going to be super acidic, right? Because they're not blowing off any carbon dioxide because they've stopped breathing. But their body's still trying to do metabolism, which means it's creating toxic waste products with carbonic acid, lactic acid, etc. So you need to ventilate these patients very effectively. This is why a lot of the times if a patient's been down for a while and you try to defibrillate them, that first defibrillation doesn't work because they're too acidic. This chart. You need this chart. I'll wait. Copy this. So, right, your normal pH is from 7.35 to 7.45. So, if you are outside of that range, but low in the acidic range, and by low I mean 6, closer towards the smaller numbers, that's lower, you are acidic. Okay, so that's here your respiratory acidosis and your metabolic acidosis. If they say, okay, the patient has a pH of 7.2 and a PaCO2, right, their end tidal, bicarb. The OH negative is bicarb. You're welcome, which is represented here. This is sodium, your bicarbonate ion over here. So if you have 7.2 and their PaCO2 is 55, but their bicarb is 24, you should suspect the patient's in respiratory acidosis. Okay, so that means that their body has determined that there's an issue. They're acidic, which means they're not breathing enough, right? So they're holding on to too much carbon dioxide. Perhaps they're a narcotics overdose and they're not breathing deeply enough to get that oxygen down to their alveoli, so they're retaining a lot of carbon dioxide. Their end tidal is elevated because now it's being stored in those alveoli. Every time they take a breath, it's a lot more carbon dioxide coming out. Your bicarbonate ion is produced by your kidneys. This is a slower process, okay? This takes a little bit of time to catch up, unless you're down here on the metabolic side where that's the problem. So that bicarb is frequently normal when respiratory acidosis or alkalosis. Now, on the other side, if you have a patient whose pH is 7.5, okay, and their PaCO2 is 25, but their bicarb is normal, these patients are alkalotic. These are the patients having a panic attack, right? They're breathing really fast. They try to get right? They're blowing off too much of the acid that they need. They start to have those carpal pedal spasms. So they're blowing off all of the carbon dioxide. They're not bringing carbon dioxide back because they're breathing too fast for that exchange to happen. But their kidneys haven't had to produce any more bicarb yet. This hasn't caught up. And then you have your metabolic side, right? So your pH, we're acidotic. This is a patient who's 7.2. Their end tidal is still normal. It's in normal range because their body is compensating through using bicarb, right? It's been a long time coming. They have perhaps stopped taking their insulin, so they aren't using normal respiratory, right? The normal aerobic metabolism. They've switched over to anaerobic they're not using the Krebs cycle. Sorry. They're using, the cheap and dirty way to make energy because they can't get glucose into the cells. So now their kidneys have responded and they have a lower bicarbonate. Or you have a patient who is here at 7.5, right? Their end tidal is normal, but their bicarb is high. Okay, this is because maybe they took too many antacids or they vomited too much and they've reduced the acid level in their system. So now they're adding more bicarb into their system. This is a respiratory is a short, fast fix. Metabolic is the long, slow fix. Okay. We talked about this.
Hey, sorry, Nicole. Sorry.
Go ahead.
Someone's mic is on. It's making like a funny sound. Someone check your mic. Someone's unmuted.
There you go. Thank you. So just some common presentations that you might see. You have acidosis, right? This is the patients who are hypoventilated, narcotics overdose, even patients who are in COPD, right? They're going to live in a little bit of a respiratory acidosis all the time because they can't necessarily clear off all of that carbon dioxide effectively. But these patients are going to compensate. They'll make extra bicarb. And you have alkalosis. Commonly you see patients who are blowing off too much carbon dioxide. Anxiety is really one of the top reasons that you see respiratory alkalosis. Any reason that the acidosis is not related to respiratory, right? Lactic acidosis, ketoacidosis, patients who took too much acid, right? Aspirin is a highly acidic medication. You'll see that these patients will potentially be in a metabolic acidosis. These patients will be breathing fast to try to blow. Again, you're trying to blow off that oxygen, but the problem is metabolic, not respiratory. And your metabolic alkalosis is usually, again, excessive water intake here. Alkaline substances like antacids, excessive vomiting, excessive diarrhea is also a potential cause of metabolic alkalosis. Cellular injury. This is really where we deal, right? There's something going on in terms of an injury, but we're seeing the larger view of it where there's some sort of systemic problem. Oh, that's really hard to see. A number of different things that can cause cellular injury, right? Hypoxia is probably the number one way that the thing that we can really fix, right? So patients in a low oxygen atmosphere, they're not breathing effectively, so they don't have a lot of oxygen. Respiratory or cardiovascular disease, right? COPD, CAD, pick one of them. Anemia, where they're not able to move enough oxygen around the body. Inflammation. Inflammation is usually relatively normal. It's a normal protective response. If it gets out of control, it can lead to like autoimmune diseases and stuff like that. But inflammation is generally protective and is usually in response to a cellular injury caused by one of these other issues. Infection, right? A number of different things can cause infection. And then chemical issues, right? You could have carbon monoxide, alcohol, pharmacological agents, heroin. Pick your poison kind of thing. This is the general way that inflammation works. There's some sort of injury caused by either bacteria, a chemical, or something, blunt injury, and it starts to release the inflammation mediators out. So you'll have leukocytes, you have ketocyanin, kinase, all of these little chemical mediators get released into the system. So it initially increases blood flow to the injury area so that it can send things like platelets, blood cells, oxygen, etc. over. And then it starts to increase the permeability. Those chemical mediators start to make the capillary beds a little loosey-goosey, right? Because then if there's some sort of bacterial agent, that's the hope, is that it will leak out into the capillary, outside of the capillaries, and not go systemic. While that's going on, white blood cells are called to the site. They are going to help in fighting off any potential infection, as well as helping with some of the repairs that might be needed. And then you have the systemic response, right, where you have the patient is going to potentially have a fever. And these are things you see. Like this is like, you've given yourself a bruise or something. This is what's going on inside of you that you don't see unless you're looking like under a microscope. We've spoken about most of these things, I believe, in terms of things that can cause injury. We talked about heat, cold, and radiation, or heat and cold during environmental. Radiation is, we talked about a little bit during weapons of mass destruction, right? So any sort of radioactive material can cause damage. Even, they have all the people, x-ray techs and the radiologists and stuff, wear the little badge when they're in the hospital to make sure that they don't get exposed to too much radiation. Nutritional issues, right? On both sides, you can be malnourished and not be able to take care of your body's needs, and you can also be obese and still not be able to take care of your body's needs. There are people who are obese who are malnourished, which makes very little sense, but you can become obese secondary to eating foods that aren't actually of any high quality nutritional value, right? So if you're not eating your veggies, you can still have issues. That's the people who eat McDonald's and only McDonald's, not a balanced diet. But those people are the ones who also potentially have a vitamin mineral excess or deficiency, most of the time a deficiency. You have to know the difference a little bit between like a water soluble, a water-soluble vitamin versus a fat-soluble vitamin, right? It's really like vitamin C is a water-soluble vitamin. You really can't overdose on vitamin C. It flushes right out of your system. B vitamins, same thing. But you have fat-based vitamins like vitamin A and vitamin E, which you can overdose on because your body stores them in fat. And then you have other issues, the genetic issues that could cause problems. Chromosomal disorders such as Down syndrome, other like random gene mutations which can predispose you to things like breast cancer, right? BRCA, the BRCA gene. You know, just a lot of fun being human. There is necrosis versus apoptosis, which is how your body tries to eliminate the threat of injury in a sick cell. So if the cell starts to become injured, right, if it has a reversible injury over here on this side, it will start to potentially swell. If it is able to control that issue, it'll go into recovery and come back to being a normal cell. If not, it will become progressively injured until it dies. As opposed to a normal cell, as it breaks down, as it starts to age, the cell's like, it's been real, guys. I'm going to be replaced. This happens very commonly in your skin. I'm going to be replaced, and it actually will more or less cause itself to have its own cell death, cell suicide. It breaks down and lets healthier, younger cells take its place. So back in BLS, I think we talk about shock and hypoperfusion, and we don't really talk about all of the kind of ramifications of hypoperfusion. Being in a shock state is extremely dangerous to your body. Your body does pretty much everything it can to avoid ever getting to this point, because once you start to go into a hyperperfused state, it's a slippery slope downhill. It can become increasingly challenging to come back and recover 100% without some level of damage. So without adequate perfusion, you're not getting to those end tissues, right? The cells inside the very end of your finger aren't getting rid of their wastes appropriately. And they start to undertake damage because now there's a buildup of toxic wastes. There's no oxygen and new nutrients coming in, and they might switch over to anaerobic metabolism, which increases the toxic waste because they're not getting the oxygen that they need. As this starts to happen and your body starts to realize, oh no, we don't have enough, perfusion going on, it sets off the compensatory response system, right? So you have your catecholamines, your epinephrine, which starts to raise your heart rate and starts to constrict your blood vessels to try to shunt blood to the core. Because as you start to shunt blood to the core, you're increasing your preload, which increases your stroke volume. And then with the increased heart rate, you're increasing your cardiac output, right? So the body's going, all right, we can fix this. No problem. We got this. We can fix it. Bring more blood to the heart will do its job and bring more stuff back to where we need it. As that happens, your body also activates what's called the renin-angiotensin-aldosterone system, the RAS. This ultimately culminates in the release of ADH, or antidiuretic hormone, which pretty much triggers your kidneys to stop creating as much urine, okay? Sometimes it can shut the urine production down 100%. This is why you see, and you have patients in the ICU who are commonly Foley cathetered, because they're tracking how much urine output they're producing. They want about 30 milliliters a kilogram an hour of urine output, because that means that the kidneys are getting a sufficient amount of blood. If they're not getting enough blood, this means that renin-angiotensin-aldosterone system is still in full effect, and they're still hypoperfused, okay? That means that their body has not been like, okay, cool, guys, we're getting the oxygen and the nutrients that we need, we're getting rid of the wastes we don't, we're happy. It means that there's still work to be done to make this patient better. A lot of times you also see that a lot of the fluid will be shifted from interstitial spaces, right? So those places like this, in between cells here and there, normal spots for fluid, the body will go and kind of suck everything it can into the vascular compartment. This is why some level of fluid administration can be helpful, because it keeps the vasculature open and it starts to help kind of rehydrate the patient in the long term. This is why we give septic patients fluid. They've sucked out all of the interstitial space fluid that they can to try to boost the circulatory load, and it's unsuccessful. This is why those patients, documentation of fluid administration is important. There are a number of different types of shock. Central shock is cardiogenic or obstructive. Obstructive shock can be caused by things such as tension pneumothorax, where you're preventing blood flow from getting back to the heart. You can have peripheral shock, which is really an external kind of issue, usually secondary to hemorrhage, though not all hemorrhages are necessarily going to be seen externally. You might have internal hemorrhage that's causing the same issue. And then you have your distributive shock, which is some sort of internal issue going on. So it could be that the patient is having an anaphylactic reaction or septic. Both of those types of distributive shock pretty much punch holes into your vasculature. So your vasculature is like this really tight woven cell structure. Anaphylaxis and sepsis releases chemical mediators that actually loosens up the bonds between cells, so plasma can sort of starts to escape. This is why you have these patients become hypotensive, is because their vasculature becomes very leaky. The problem with that also means that that really tight bond that you see is very similar to what you see inside the GI tract. So as those cell spaces open up in the GI tract, the bacteria gets loose. Most of the time, patients who are in anaphylactic and septic shock will end up with secondary infections due to GI issues. Even regular, like peripheral hemorrhagic shock, the most common cause of death, if the hemorrhage is fixed, is an infection secondary to the GI bacteria going for a walkabout throughout the body. Then you have neurogenic shock, which is distributive, but it's kind of unique in so much as you're not losing fluid or anything from the vasculature. Your container just gets really big and you don't increase the amount of fluid inside of it, right? So usually you have there's some sort of spinal column insult where you lose control of your vasculature beyond the point of that injury, and the vasculature just goes, oh no one's controlling me anymore, and just opens up. So now you just have a really big container with the same amount of fluid, and shows up as shock. Management of shock, right? It's not going to change a whole hell of a lot from when you were doing BLS, right? You're still going to do the same things that you did, right? You're going to keep the patient warm. You're going to administer oxygen appropriately because they need the oxygen to get to their end organs. You're going to try to improve their blood pressure as best as you can. Though we are going to add some tricks to your toolkit, whereas, okay, maybe you're going to start an IV. Okay, maybe you're going to support that cardiovascular system a little bit with some fluids. Really, in the grand scheme of things, you don't want to give this patient or a shocky patient too much fluid, unless it's like a burn shock or a septic shock, which they need the fluids. But like a hemorrhagic shock patient, you don't want to give them too much fluid because you're just making their blood like a really weak Kool-Aid, right? They need blood products. They don't need you to wash them out. What you do have the ability to also monitor is end tidal. As end tidal starts to decrease, it's an early sign of shock, right? Because that carbon dioxide isn't able to get back to the lungs and be traded out, okay? We also have the ability that we can start, in certain types of shock, you can start using vasopressors to help improve the function of the vasculature. In most shock states, norepinephrine is the vasopressor of choice. Just an FYI. Once a patient starts having failure of multiple organ systems, their mortality rates start to increase significantly. So you most commonly will see that the failure starts to end up with the kidneys. The kidneys do not function well under low blood pressure states. So you might have a patient who has a hemorrhagic injury to their liver, and their liver's not functioning, and now they've lost so much blood that their kidneys also aren't functioning. that starts to qualify as a multi-organ dysfunction syndrome, or syndromte, which apparently I can't spell. That's significant. That's a problem. Okay. For the most part, we are not going to be dealing with a lot of these patients because we are still dealing here in the primary section, right? There's been a direct injury. We are coming right after that direct injury has happened, and we are trying to stabilize them before they progress into other organ failures. A lot of the times there's things that can start to cause injury and infection, like the septic shocks. You might see patients who are already in multiple organ dysfunction, or MODS. Your immune system is pretty good. I'm pretty sure that a lot of us are very much more in tune with immune systems now that we've had COVID for the last year. I'm kind of understanding what's going on, but the real breakdown, your primary response happens when you have the first exposure. So if you have an exposure to a bacteria or a virus, your body jumps into action. And it might stop here, okay? Right? It might just be like, oh, you've had an exposure, you're not going to get any further sick. But your body does start to create secondary responses, right? These are your antibodies. You've been exposed to a virus. Your body's like, whoa, what's this? This is new. Creates antibodies. The next time you are exposed, it's like, no, we recognize this now. Shut it down. Okay. Depending on how healthy you are, you might be exposed to a virus or bacteria. If there's not enough of that virus or bacteria to make you sick, that could be the end of it. Your body can attack it effectively and you won't get really, really sick. Maybe you'll have the sniffles for the day. But you have a lot of different parts of your body that are helpful and protective. Your skin, the number one and biggest organ in which that helps. You have your mucosal membranes, nasal hair, just your epithelial, the cilia inside your respiratory tract that kind of helps push everything back up and out of that system. Your body's very good at trying to protect itself. And then you have a number of other things. The complement system starts to go into effect. Your memory B cells, your T cells, which is your antibodies, and your T cells are pretty fun also. My personal favorite are the natural killer cells. They just kind of go out there and kill stuff. They are the ninjas of your immune system. So you have a number of different ways that your body produces an immune response. Antibodies, once your body recognizes that there's an invader, the antibodies attach itself and tag it, and then the body's then like, oh, that's what we have to attack, and it just gives it a sign. It's like a big neon light. An immunogen is an antigen that generates an immune response against itself, whereas a hapten is a substance that does not normally respond to an immune response. So, you have different components of your immune system. The hapten is what helps your body initiate a later antibody response. It needs to be combined, where an immunogen does it itself. It's like your white blood cell, kind of components. Humoral immune response, you have a number of different white blood cells, right? And they will differentiate depending on what you need. You have a macrophage, actually will engulf an entire antigen and then break it down. You have antigens that bind to the B cells and the helper T cells, help stimulate production of cells in response to a specific invader. Two things that you should probably know: you have your IgG and your IgM. These are the most common antibodies that you see, and this is also the common antibodies that they test for. Your IgG means that there's some sort of active infection. Your IgM is your memory, M for memory, antibodies. These are the ones that they usually test for to see if you're sick with something. They coat the bad guy and then they cause them to clump, and then it makes it easier for the white blood cells to attack. Depending on what you have an infection from, depends on which kind of white blood cells are produced. So you have your eosinophils, your basophils, your neutrophils. They all respond to different things, be it virus, parasite, bacteria, fungus. Your body will be like, that's a virus, and then produce more eosinophils or neutrophils, depending on what's going on. You also have T cell lymphocytes, which are kind of, they hang out over here. They secrete cytokines. Cytokines are what was causing significant inflammatory responses and like cytokine storms during COVID, which was kind of creating a huge issue, as well as like the flu. I want to say like 4 years ago, when the flu was still a thing and we gave a crap. People were dying from this one particular strain of flu because it was producing cytokine storms. And it was just becoming very toxic to the body, and they couldn't control it because it was the body's natural immune response kind of going haywire. It was a little too good. Most basic breakdown. B cells are outside, T cells attack inside. T cells are what's most the component of the immune system that's affected most by HIV. Okay, and this is why they are the ones, HIV patients are the ones who die from like secondary infections, because they are unable to produce enough effective T cells. Killer T cells will actually destroy the antigen itself, whereas helper T cells just help kind of like trigger other cells, like, hey guys, there's an infection. Everyone gather in the town square. We have to go kill it. Memory T cells remember what to do. Okay, so you have a whole number of different things within your bodies that help keep you healthy. And we don't really get to see a lot of it. We talked about this already. Interferon is produced by cells invaded by viruses. You can actually get patients who have like autoimmune diseases can actually get interferon infusions, which is supposed to help with the inflammatory response in the body to help reduce it. But no matter what, your body kind of goes, even if the tissue's injury is internal or external, it follows this cascade. There's some good things to know. You don't really need to go heavily in depth on how the immune system works, but you need to know like inflammation is a natural path. Sometimes people get a little overenthusiastic, right? You take NSAIDs to reduce their inflammation. And you do need a certain amount of inflammation in your body to heal normally. So sometimes people actually like, oh, I twisted my ankle and I took some, Tylenol and it feels better. Okay, but you didn't really fix it. Inflammation does a lot of things to kind of help support your immune system as a whole, so that you can overcome infection or injury, etc. When you have an inflammatory response, these are all the things that kind of come rushing to the scene. So, right, maybe you get an injury, you start having inflammation that you see through pain, redness, and swelling. But then underneath, you have a whole number of people who jump. Yeah, if this was not on the review sheet, don't worry about it too much. I'm going to cover it because it might pop up in the national, and then you have something to look at. But if it's not on the review sheet, then you don't need to worry about it for this test. But yeah, it goes through the cascade. All right, so you have a bacteria that is introduced, white blood cells start to come, you have a complement, inflammation happens, cytokines happen, and your body also does a good job of like kind of reducing all this stuff while it's also happening. But yeah, just be familiar with some of these things. Mast cells are going to pop up again when we get into anaphylactic reactions, because they're the glitter bombs of your immune system. Okay, so they hold on to histamine and leukotrienes and prostaglandins and all of this stuff, and they're like these little cells, and then they like wander over and they're like, ooh, we're allergic to this, hit it with histamine, and they just explode themselves and release histamine into the system, and that's what causes like that allergic and that and or anaphylactic response. So mast cells, remember them, they're going to show up again when we talk about anaphylaxis. Coag is important to kind of understand. for a number of parts right here. So it doesn't matter if it's an internal or an external injury, you follow the same, what's called the common coagulation cascade. What happens is as you start to lay down the fibrin, your body also starts to release an enzyme to break it down. So this is what happens when patients who are really, really sick, they go into what's called DIC, or disseminated intravascular coagulation. So they're hemorrhaging and making microclots at the same time because they've run out of all of these guys, okay? And they're no longer able to lay down clots. But things you need to kind of just be vaguely familiar with, you have patients who are potentially hemophiliacs who might be missing one of these factors. Christmas factor is one of them. There's a von Willebrand factor that's in there. That's also in here somewhere, which on this particular chart, that will also create hemophilia. If you have a patient who doesn't have adequate calcium, hypocalcemic patients, they won't clot well, okay? Patients who are cold, they won't clot well, okay? Because they're unable to make this coagulation cascade happen effectively. And this is why we keep our trauma patients warm. We're not going to talk about this. This is another system that the body does.
There's something like TXA where we talked about that with how it carries oxygen for blood in trauma patients. Does that help people who are missing certain factors, or is that like a separate type of blood like movement and everything?
No, it actually works really well in here. So what TXA does is it prevents the fibrinogen from turning into it prevents the fibrin clot from being broken down because it keeps it's a fibrinogen. Fibrinogen comes back around. It won't let this fibrinolysis occur. So
they can use it in medical patients too, not just in trauma patients.
Yes. It's commonly used in trauma patients, but they can use it in medical patients as well. So like patients with like a bad GI bleed or something, they might be able to use it to help stabilize the clotting that's going on. Not sure of the research behind it, but I know that they have a lot of good research supporting it in trauma.
Gotcha. Thank you.
We're going to skip that. So everything, once you have an injury, your body does try to repair it effectively, right? So there's a number of ways that healing can be kind of dysfunctioned. As a little kid, probably the most common is you've picked the scab off of it and started bleeding all over again. Depending on which cell is injured, how is the body going to then heal it. Permanent cells can't be regenerated and usually just restored with scar tissue. But it really depends. Again, nutritional status is a huge systemic issue when it comes to proper healing. You see this a lot in the elderly who, like, they have the open wounds, like, that take a really long, with diabetics, it takes a really long time for it to heal. But we're not going to go too deep into that. Some people live in a chronic state of inflammation. It could be secondary to like an antigen that's always there, like, kind of just like something that's irritating the immune system. It could be like pollen or something, but it could just be chronic. Comorbidities like diabetes and high blood pressure can create chronic inflammation. Autoimmune diseases, persistent infection. There's patients who have all sorts of like different issues, like Lyme disease can cause chronic inflammation if it's not managed appropriately, etc., etc. We're not going to talk about this too much. Basically, when you're talking about immunity and inflammation, your body uses inflammation along with the immune system to respond. So if you have a patient who is allergic or anaphylactic to a certain thing, it's because something here has gone way off kilter, okay? We don't need to know the specific types. We just know that, it can get worse, depending. Immunodeficiency is an abnormal response where the immune system doesn't give you enough of what you need. A lot of times this is seen in patients with like HIV, stress-related immunodeficiencies, patients on long-term prednisone treatment for something else. Most of the time they'll be treated with like gamma globulin or a bone marrow transport if it's a cancer. Sometimes blood transfusions can help prevent. Know the difference between factors that cause disease between controllable and uncontrollable. A lot of the times we can't control, our genetics and stuff like that, or gender, but we can potentially control parts of our environment, our habits, etc. And those are things that we can do to help prevent ourselves from being sick. Whereas there's some things that we really don't have any sort of issue in. I think we might have covered this collectively over the past year when it comes to COVID and discussing risk factors to getting sick, new cases, how many cases, right? So how present is the disease? How many deaths does it cause? The morbidity and mortality, the prevalence over a period of time, right? So we flatten the curve. Did we not flatten the curve? When the new cases in a population started to spread significantly and across the world, we got to end up in the pandemic range of stuff. Recessive genes, we're not going to really go into this. You're not doing a gene thing on people. Just know that if a patient has a parent who has an issue, like someone who in their family has high blood pressure, cardiac disease, etc., they're more likely to have it than if their parents did not have that disease. There you go. Especially on the psychiatric sides, that tends to run in clusters. Schizophrenia, bipolar, very commonly caused by like dopamine imbalances. Neuromuscular, also same thing. A lot of Huntington's disease, MS stuff also runs in families. Cardiovascular, all of these things tend to run in families. Looks like almost anything you can ever come up with. Isn't that great? We're not going to talk about that. You don't need to know that. This is a little hard to see, but this is how your body adapts to things. Is kind of associated with how your body also then responds to things like PTSD. So in stage 1, there's alarm. I know you guys probably can't really see that. It's not a great color. This is your fight or flight, right? Your body releases epinephrine and your sympathetic nervous system is stimulated. And then if that continues, that response is not relieved, you enter into stage 2 resistance. This is when your body starts to release hormones like your cortisol and stuff like that to increase your blood sugar and maintain blood pressure. Endorphins start to grow, growth hormone starts to become released because your body's like, all right, well, we're going to need to deal with this for a while. Let's get brolic. And then at some point along this stage, your body actually enters into what's called exhaustion. Your adrenal glands cannot continue what they're doing, and you start to see like a overall collapse. This is, when they talk about all the celebrities who are going into exhaustion and stuff like that, it's sort of like this. Like you know it yourself too. When you overdo it and you stress yourself out and like have a lot of things, like paramedic school, for example, you'll hit the exhaustion stage where you'll get sick really easy and stuff like that. Oh, good. Questions? Let me see how many slides this last one is. Nah, it's not too bad. What was that, 12? 20? All right. Questions, thoughts, concerns? We'll do the last one. It's critical thinking and decision making. A lot of this stuff you're probably already doing in your normal day-to-day practice. We're just going to talk about it so you know that that's what you're doing. Maybe. So let's start with a little case study. Dispatch to private residence for a 60-year-old female complaining of weakness, fatigue, and dizziness. Upon arrival, the patient's daughter is the one who meets you at the door. She's the one who called 911 because her daughter doesn't think that her mother's acting right and thinks she just has a cold. Daughter's concerned that there's something else. Your primary assessment, your patient does have their eyes open and is alert, but they're a bit on the flat affect side, so right, they're not really responding. They're not making a lot of facial expressions that you would really expect. Airway's good. Breathing is a little fast, but they have good tidal volume, and they have rapid pulses bilaterally at the radials. All right, so quick question. In terms of what your initial assessment is of this patient, are they stable or unstable?
Potentially unstable.
Anybody else?
They're stable.
Yeah, they're stable.
Do you have an index of suspicion for this patient, though?
I'd say
Yes.
potentially
Yeah.
unstable.
Okay. Where would you say if she's got bilateral radial pulses, where is her blood pressure?
Above a 90 systolic.
There you go, above 90
You
systolic.
know,
All right, cool. Patient's apologizing, saying she's convinced she just has a cold. She woke up at 0600 feeling unwell, short of breath, no other complaints, no cough, fever, chills, body aches, nausea, or vomiting. What's your initial concern?
If she used 0600, I'm RMAing her.
It's not 0600, but that's when it woke her up.
I'm kidding. Okay.
So what are some of your issues? Or what, I guess,
Wow.
or a question you'd like to ask this patient?
well, she says she woke up
Mhm.
feeling unwell and shortness of breath. So
Was it the shortness of breath that woke her up?
There you
Does
go.
she have COVID?
Does she have COVID?
exactly. So
Okay, good. But exactly, I think that's important. Does she usually wake up at 6 o'clock in the morning, or did how she felt, that what woke her up? Good, because that's going to really change your potential questioning. So, her skin is moist, pale, and warm. Pulse is about 110, blood pressure 130 over 82, respiration's 32 and regular, and she's about 95% on room air. Initial thoughts, concerns?
Oh
Oh no.
Fix the respiration.
This
Yeah, respiration.
respirations are up there.
Okay.
yeah.
The heart rate's getting up there too.
Okay, so what are some of the things that you would suspect?
Cardiac condition.
Okay.
Cardiac event going on.
I would definitely auscultate, listen to
Right
her
now.
lung sounds, see
Good.
what's going on.
Good,
yeah.
good.
Cardiac,
I
respiratory.
mean, right now
maybe
she's
an infection.
compensating.
Yep, right now she's compensating.
Maybe an infection.
Okay, good.
I mean, I would definitely probably throw her on a non-rebreather.
Okay. All right. So we also talked a little bit about acidosis and metabolic versus respiratory acidosis. Would you necessarily want to fix her respirations, or do you want to just support her oxygenation?
Or
The oxygenation.
Okay. Right?
yeah.
Good.
Try and get a BGL.
All right, BGL. Let's see. So there we go. Emphysema, diabetes, and high blood pressure. She's on albuterol, singular metformin, and lisinopril. And she's allergic to penicillin. So, albuterol. What's she taking the albuterol for?
Emphysema.
Any potential wheezing.
Now,
any,
the other thing too is with her respirations being 32, she has emphysema. Is she getting full lung capacity at that point for her normal baseline?
Or is that also maybe her normal baseline? Maybe she's got to work a little harder to breathe. Or maybe her normal baseline's 28 and 32 is not really out of range. So again, good considerations. Singular, what's singular for?
Allergies.
And the emphysema. Metformin's for would you suspect she's a type 1 or a type 2 diabetic?
Type 2.
Yeah.
Type 2.
Okay, and lisinopril. Okay, anyone know what kind of medication lisinopril is?
It's high blood pressure, like an Diuretic too.
It does not have. There's no antidiuretic. Anyone know what kind of type? What realm of blood pressure
Is it an
control?
ACE inhibitor?
It's
It
an ACE
is.
inhibitor.
It's an ACE inhibitor. Good. Does anyone know there's some complications with ACE inhibitors that a lot of people aren't aware of? But ACE inhibitors can cause angioedema. Just randomly, just cause angioedema, not because of an allergic reaction. It just goes, hey, guess what? Angioedema. Just so things to just take into consideration when you're talking about your patient. So, list of differential diagnoses. I think we covered a bunch of those so far. What other things would you want to do to kind of narrow down your differential diagnoses?
Check for fluid in the lungs.
Is there fluid in the lungs? All right, so good set of lung sounds. What else?
I'd want a BGL.
Mm-hmm. Okay, BGL. What else?
KG.
You could do your assessment, your focus assessment. I would say you could check for muscle retractions. You could check for
some pedal edema, probably.
Pedal edema, the muscle retractions. All these, very good, very good.
Also, just a history if this has happened before in this type of status.
Good. Has she been hospitalized for anything similar, right? Has she been diagnosed with anything? Has she started any new medications, right? All of these things.
Any recent surgeries?
Recent surgeries, right? Good. All right. So this is kind of what you're doing when we're talking about critical thinking. And I'm pretty sure we're all here already because you've been functioning as BLS providers for at least a little bit. But eventually, what we kind of do is when we're talking about patient history and stuff, we're gathering information, we're evaluating what the patient's telling us, and then we're synthesizing things and putting them together to kind of either gather more information or to come to a differential diagnosis, okay?
Well, the other thing we didn't add into this, Nicole, is the environment that she's in.
Okay.
You know, are there smokers in the house? She has a history of emphysema. Are there any other allergens that could be affecting her?
Good. So these are questions, other questions that you would potentially want to ask. So as we start to gather, or we have a history of the signs and symptoms, pertinent positive and negatives, there's all the information, the questions that we ask. That helps us get to our differential diagnosis. When we get to a differential diagnosis, that's when we start to make an action plan, right? So in order to develop an action plan, we look at what our protocols are, AHA algorithms, any standing orders, or any other things that we might want to add to this, maybe you want to go get a discretionary order from a physician through medical control, right? So this is breaking down the process that we are kind of already using, but not necessarily thinking of all the pieces. Understanding what your judgment is helps make better decisions, right? So if you don't want to come in with biases or anything like that, you want to be able to look at everything very face value, dig a little deeper if you think something doesn't make sense, and then come to a sensible conclusion. We're not going to do that. You also need to be able to work under pressure. I've seen some people really kind of fall apart at the seams when there's something that looks really scary, right? Patient might be super stable but has a gruesome injury and people are falling apart. And then you have patients who are able to pull from their experience and the previous jobs that they've seen to kind of build what their knowledge base is, and then are confident in what their clinical skills are, like IVs and interpreting EKGs, so that they can work well under pressure. And this is a lot of muscle memory, and this is the stuff that you're going to be developing while you're going through this program. A lot of the times you also have to kind of fall back all the way onto your BLS skills, right? You need to be able to fall back on your ABCs and say, hey, let's start over. Like if I got lost or I got, kind of confounded by what's going on, I can just do another set of lung sounds. I'll double check a blood pressure. I'll do these things to give myself a little bit of time. Don't stand and stare. Do something, okay? Even if it's taking a blood pressure, counting a pulse, do something. That is for the patient's comfort level, okay? That they don't want you to sit and stare at them looking panicked. I'd like to say control your eyebrows. Again, we've talked about a lot of these things already. I think you're doing this already. You're looking at the situation. You're stopping and thinking about what you're going to do. And maybe you're not stopping, but you're definitely thinking about what you're going to do. you're making decisions about what you think is going to be best for the patient, and you're remaining calm. And then when you're done, you check your patient, start all over again, right? This is an ongoing cyclical process that we kind of do all of the time when we are managing a patient. So, some of the things that let's talk about this scene a little bit. What information are you gathering from this patient, from this scene?
Robbery gone wrong.
Not even that. He probably fell in the alleyway.
He probably just fainted. Since
They're bagging him.
They're
so he's not-
bagging him. So
I feel like he
They're
fainted.
assisting him.
Critical.
okay,
Could just be a man down call. Someone found him.
okay. Y'all are being really nice. What's the number one thing that I would be
Overdose.
overdose? Overdose.
Yeah.
Definitely.
Or dead guy.
He may not be safe.
He might be safe. All right, so let's look. So, and this is we do a little bit of judgy. Is he dressed relatively well?
No, he looks homeless.
Could be,
I don't think so. I
No,
think he's just
think
like
it's fine.
coming into the store.
That's a leather jacket.
Yeah. All right. So leather jacket. That's
Clean.
he's
It
doing
looks
good.
like he's taking the jacket off of him.
Yeah, because if you look at his shoulder here, he's got the patch. He's trying to get him undressed, and he's even doing it nice. He's not cutting it like.
You can't always throw off the clothes though, because people donate clothes to Goodwill. It makes them feel better about themselves,
Uh-huh.
and then people go get it free. So homeless people a lot of times have very nice clothes.
I've seen a variety, and he might not have been homeless. He could be homeless, but not homeless for long. I think shoes and socks are probably the best indicators of whether or not the patient is homeless, because most of the time they'll grab whatever shoes they can, and the socks tend to be hospital socks just because they last. Socks are really hard to come by in shelters. So
Where's the one EMT's gloves?
great question. He's not. That medic is not wearing gloves.
He's a volley.
Maybe. All right.
NYU.
Is this scene safe?
Not really.
Not 100% clear.
No, there's way more people wandering than there are workers.
Yes.
I mean, it looks.
I don't know about that. There's 3 workers in the back who are coming from behind the ambulance, plus 3 on scene, so that outnumbers the amount of citizens on scene.
Is this guy?
It looks like an
alleyway.
Is this guy?
I'm loving this guy in the green jacket.
This is 5
1,
if you
2.
include the man down.
Yeah, I think this guy's a bystander. This guy's a bystander. He's got his hands on his hip.
There's no PD though, so
together.
Oh yeah. You stage the ambulance inside the alleyway.
That's foolish, in my opinion. Where's the other ambulance? You can't tell me that 1, 2, 3, 4 came on by them collectively in this ambulance.
Maybe they did. There could be volleys.
It's probably a responder, for being honest.
It looks like it's in Europe. Don't they have like the motorcycles that they travel on?
Some of them do, yeah, they do.
I don't know. I'm just.
Who knows how many of these witnesses actually know what happened anyway? So they might be.
Volleys roll deep, man.
No one's throwing nothing.
But yeah, so maybe this guy looks like he might be the only one who's got the most information about what's going on, because he's like up in this guy's business right here.
The guy in the yellow is probably the volley chief.
Yeah, right. There's a volley chief somewhere.
That dude with the backwards hat knows which pocket the rest of the dope's in.
Probably. It actually, if you look really
Fingerprints
close,
on it.
If you look really close, it actually looks like he's the one holding the mask. So hey, we took some initiative and we volunteered some resources. So when you're looking at the concept formation, you already have an idea in your mind of what your plan of action is going to be. When these guys show up, I'd be like, hey, can you do me a favor? Can you just get this guy out of the way? Like, this guy makes me uncomfortable. I don't like having somebody behind me. Maybe you move this lady. She's also kind of in a spot that I can't see well. Maybe we're going to take over for this guy. Maybe we already have a nice relationship with this guy. He's cool. You're saving his buddy. And he's going to do everything he can to help. He might be the only one with some information, right? So he could stay. This guy's moving along. This guy's moving along. This guy, he's sketchy. I don't like him. He can get, backed up a little bit, a couple feet off a scene. So yeah, there's always a lot going on, but it helps you build up like this story, right? So we already just built a really nice story for this guy, and we have zero information. So this is what's going on in your head collectively all the time. I don't know if it's still available, but if you ever want, it's like 24 hours to save your life, and they follow the UK or the UK EMS.
What are you eating, Hazel?
So you're going to understand what's the things that are going on. In this particular episode, this girl had been hit by a truck. Not like a little truck, like a big truck. And they actually ended up doing they opened up her chest in the middle of the street, because in the UK they have this guy's a doctor, an ER doctor, and they put up these big screens around serious calls, and they'll perform surgery right in the street. We're not gonna do surgery, but we do need to understand what information we've gathered so that when we get to the hospital, you can kind of help this guy out, because we don't do this here, not in our system anyway. At some point, your general impression becomes your working diagnosis, right? You come in, you do a 3-lead, you do a 12-lead, patient's complaining of chest pain, and you see ST elevations, you're like, heart attack, aspirin, nitro, oxygen, just, transmit to the telemetry and let's go to the hospital, right? That becomes the course of action that you're going. You have all of these protocols and standing orders and like a logical a logical movement through all the protocols and stuff so that you can treat the patient appropriately.
Nicole, is it progression that you're looking for?
Thank you. Yes, logical progression. Logical progression through your treatment protocols and what the patient is doing. And you're always reassessing. So if his chest pain has gotten better, maybe you're not going to give him nitro anymore, okay? Until he starts saying, yeah, no, the chest pain's back. Okay, cool, we'll redo the nitro. So you have to constantly apply what you know to what's going on in front of you. This also means that you're going to reflect, right? This is kind of reflection and reassessment is kind of, they kind of tie in. But this also reflection is going to be like, all right, well, I've checked and I've reassessed, but like maybe they're missing something. Maybe I need to go and ask this patient more questions. Maybe there's something that they haven't shared. Maybe we're cool now. Maybe we've built a rapport that now they'll tell me a little bit more like, hey, did you take anything you really shouldn't have, or hey, were you, you're saying you're having chest pain right after that argument, now that you're not in that space anymore, you feeling a little bit better before we start, really treating you kind of heavy. But you need to always be gathering new information, talk to your patient, see how they're doing. So that's reflection while you're in action. And then there's also reflection on action. This is the post-call debrief. And this is going to depend on you and your partner and a lot of different things. Because sometimes you have a partner that you're like, hey, let's talk about that. What do you think we did really well? Do you think we should have done this? Do you think that maybe we should have given him nitro sooner? Or do you think we should have, maybe we should have cardioverted, or instead of going with the fluids and the medication route, what can we have improved and what went really well? Like, you always have those cardiac arrests where you go in and it just smooth. Your partner's doing one thing, you're doing the other, you're communicating, you tell the BLS is doing a great job CPR, the firefighters are getting all the shoes out of the hallway. Everything is perfect, right? And then you have those cardiac arrests where the suction stops working and the BLS is like freaking out and you're not able to get the tube and it's just a mess, right? So where can we be better and what went well? Maybe you saw while you were on scene, maybe you have a patient who's got a new medication. That's a gap in your knowledge, which, hey, let's look it up, right? Something so easy. Ask the patient, hey, what's that medication? You Google it. All right, great, cool. I remember this now. Okay. Next time I see this medication, I'll know more about it. Maybe you have a patient who's not presenting in a way that you are 100% familiar with. That's going to be added to your toolkit. So when you see somebody in the future with that same kind of vague description, that maybe you can help them out. And also articulating why you did or did not do something, okay? Because then you get to the hospital and the doctor's like, well, why'd you do that? And you're like, well, the patient had this, this, and this, and I thought that it would be ideal to help them with, through this method or whatever. That was just the same one in bold. we talked about this a lot already. These are just articulating, right? You're going to read the scene. What's going on? You know, that guy who was on the ground 2 or 3 slides ago, the ground looked wet, right? Environmental conditions. Maybe he's hypothermic. You know, maybe he is homeless and he was outside and it was raining and he couldn't find shelter. So now he's hypothermic and he's unwell and you have some sort of, you know, non-drug related issue going on. What signals are the patient giving you, right? Is the patient kind of like very open, very chit-chatty, and you're like, okay, or is the patient kind of seem like they're hiding something? When you find life threats, are you able to react to them appropriately and immediately? Are you constantly thinking in your head, okay, I see this, it's this, and this? Can you change your plan after you've reevaluated, right? You've done something, you gave a patient nitro, it didn't help their chest pain. Maybe it's not cardiac in nature. Maybe there's something else. Let me listen to lung sounds. Maybe you'll do another EKG. And then always reevaluate your practice. You don't necessarily have to talk about it with your partner, but maybe you should, you know, do some Googling or see if you can follow up with the patient with your QA/QI director and see if there is something that you missed, you know, in terms of a good question to ask, or, you know, there was an imaging or something, a zebra, right? Maybe there was some medical zebra going on that you otherwise will never know about. So, that's a dat. All right, guys. We good? Do we have any questions?
I have a question, Nicole.
Mm-hmm.
How do you handle a situation where, like, a patient, you don't think a patient necessarily needs a medication, but they're asking for it? So, like, for example, I had a patient, chest pain, we gave her aspirin, she felt better, but then she was like, I want the spray one, which is like the nitro. We got ALS there, and like, she was like, I feel better, but I want nitro. Give me nitro. Give me nitro. And like, I don't know. I ended up having to drive their truck, so I don't know if they ended up giving it to her. But like, how do you handle that situation? Like, you feel better, but you still want the
medication.
The medication.
I mean, I
Did you?
guess that kind of is a combination of different things that you could do. Like, for example, if the patient like doesn't have vital signs that support it, be like, hey, listen, like, we really can't give you nitro right now. Like, it's your blood pressure's not good enough. You know, we don't want to make you sick from it. You know, this medication has, I know you've used it in the past, but this medication has side effects that, you know, we aren't able to control in the ambulance. Let the hospital.
That's right.
You know, just be kind of diplomatic about it. Yeah, but be interesting to see how they
But
handle that.
would it be to say that we don't have it available at the time?
As a BLS provider, yes. As an ALS provider, that's a slippery slope.
Okay.
Because again, you could, and in the city, you're going to see this too. There are people out there who investigate EMS to make sure that you're doing the right thing. So you might the patient.
We had a crew we had a crew the other day that, for whatever reason, she never calls ALS when they should. But the one was complaining of just straight leg pain, no isolated injury.
Okay.
And against her partner, she called ALS for her pain management. ALS got there, conditions board showed up. They're like, we don't give pain management for just leg pain.
Okay.
And she refused to get on a stretcher with the BLS to begin with. As soon as ALS got there, she's like, all right, fine, I'll get on a stretcher.
Yeah, it's sometimes they send the people out there.
Supportive, but it wasn't an isolated injury, so they weren't going to give it.
Well, yeah, it's knowing your protocols and a whole ton of other things, but you know, sometimes patients just want to hear what they want to hear. You know, calling ALS for that, you know, BLS, yeah, you should be somewhat familiar with ALS protocols, but you're also not supposed to know. Like, as a BLS provider, like, hey, I can't give you medication for that because I'm not, you know, but BLS doesn't necessarily need to understand the intricacies of our ALS protocols. You always get a higher level of medical authority in there to help. Doesn't hurt. Sometimes just having a different face sometimes is supportive in terms of getting patients to do what you want them to do. Like, can we get in the stretcher? Like, no. Okay, new people. Can you get in the stretcher? Sure. People are weird. Any other thoughts, questions, concerns? All right. Sounds good, guys. I will see you all Wednesday at 7 a.m. Please bring any questions that you might have. And other than that, have a lovely day.
Thanks, Nicole.